guys, welcome to our Next. Today we are going to discuss about some high yield points about fibroid uterus. So fibroid uterus, it is a kind of tumor which arises from the uterine myometrium. So let's begin. So in which age group you will mostly find fibroid uterus is the reproductive age group, and the reason behind this is the fibroid uterus, it arises with the influence of estrogen and progesterone hormone. The fibroid uterus is mostly seen in African American races. Some interesting facts about the fibroid uterus are: smoking is actually protective for fibroid uterus, and this is due to smoking can cause hypoestrogenism, and as we know, fibroid uterus are influenced by estrogen, so smoking is protective for it. Second interesting point is nulliparous women have more risk of getting fibroid uterus, and the reason here again is more estrogen exposure. Another fact that you might know is, what is the effect of pregnancy on fibroid? The answer is, it is unpredictable. Usually, there is not much increase in size during pregnancy. Now, a little more about the genetics of fibroid. So, there are certain genes which are involved in development of uterine fibroid. Some of them are MET12, HMGA2, COL4A5A6, gene for fumarate hydratase. This gene for fumarate hydratase, it is actually responsible for hereditary leiomyomatosis or HLRCC. So, one gene is there, that is MLH1 gene, that is not responsible for fibroid. It is actually responsible for development of endometrial carcinoma. Leiomyoma, it can create hyperestrogenic environment, that is more estrogen in the bloodstream or more effect of the estrogen on the tumor. So how does it achieve that? So there are mostly three mechanisms for it. Number one is, inside the fibroid tissue there is more density of estrogen receptors, which causes increased estradiol binding. Secondly, it converts less estradiol to estrone. So here one fact that you must know, the forms of estrogen, one form is estradiol, another is estrone. Estrone is the weaker form and estradiol is stronger one. So if estradiol is less converted to estrone, so the stronger estrogen is more, leading to hyperestrogenic environment. The third mechanism is increase in cytochrome P450 aromatase enzyme. This enzyme actually converts androgen to estrogen. So these are the three mechanisms by which leiomyoma can create hyperestrogenic state. Now about the development and types of leiomyoma. All of the leiomyomas or fibroids, they originate intramurally. That means inside the myometrium. Let's talk about some important types of fibroids. So what is the most common form of fibroid? That is mostly 75% cases it is seen, that is intramural fibroid. So if you look at the picture, this fibroid, you can see it is inside the myometrium of the uterus. This is known as intramural type of fibroid. Now, which is the least common type of fibroid, which consists about only 10%, that is subserosal type of fibroid. Here you can see this is the serosal layer of the uterus, and this is the fibroid that is actually growing outside the serosal layer. So this is known as the subserosal type of fibroid. Now, which type of fibroid is most symptomatic in nature? That is submucous type of fibroid. And you must notice that submucous type of fibroid also causes menorrhagia, that is intermenstrual bleeding. Here you can see this is the mucosal lining of the uterus, and this fibroid, it extends in the lumen, crossing the mucosa. So this is known as submucosal type of fibroid. There is another type of fibroid that is called as parasitic fibroid. So what is parasitic fibroid? That is also known as intraligamentary fibroid. Here you can see this fibroid that is actually situated in the broad ligament of the uterus. So this is known as intraligamentary fibroid. Why this will be considered as a parasitic fibroid? That is because this fibroid gets blood supply from its surrounding structures, and rather other fibroids, all of the fibroids, they are getting blood supply from the uterine circulation. But this broad ligament or parasitic fibroid, it is getting blood supply from the surrounding structures, not from the uterine supply. So it is considered as a parasitic fibroid. This kind of parasitic fibroid can cause compression of the ureter, leading to hydroureter or hydronephrosis. So what are the other types of fibroids that we can see here? So here one fibroid you can see here, that is actually cervical fibroid. It can be there. You can see one kind of fibroid that is protruding outside the cervix and is attached with a peduncle, that is known as pedunculated cervical fibroid. Here you can see another pedunculated fibroid, that is pedunculated serosal fibroid. Now let's talk about the clinical features of the fibroid. The most common clinical feature of fibroid is excessive menstrual bleeding or menorrhagia. You must remember a concept the position of the fibroid plays a vital role in the cause of menstrual bleeding. If the fibroid is more towards the uterine cavity, then the bleeding will be more. And if the fibroid is more towards the serosal side, then the bleeding will be less. The next clinical feature is metrorrhagia or intermenstrual bleeding. That is more seen in submucous type of fibroid. The next symptom is dysmenorrhea or painful menstruation. There can be polymenorrhea when the fibroid is associated with polycystic ovarian disease or pelvic inflammatory disease. Associated symptoms can be there like urinary retention, constipation, and frequent urination. These associated symptoms are due to compression of the urinary bladder or the rectum, which may give rise to these symptoms. Now about metrorrhagia, one important thing is if it is seen in more than 40 years of age, then you should advise dilatation and curettage and send for endometrial biopsy to rule out any endometrial carcinoma. Now another thing is known as progressive menorrhagia. This means the menorrhagia will be more with time, it will progress. And why this happens is a fibroid which originates intramurally but gets converted to submucous type. So there will be increased vascularity, increased surface area, and also endometrial hyperplasia. These three mechanisms will give rise to progressive menorrhagia. Now a little bit about broad ligament fibroids. There are two types. One is primary broad ligament fibroid or true broad ligament fibroid, and secondary or pseudo or false broad ligament fibroid. So primary broad ligament fibroid, it basically arises from the uterosacral ligament or round ligament or broad ligament tissue. And the most important part, the uterine vessels, they lie medial to it. Whereas secondary or pseudo broad ligament fibroid, it will arise from the lateral wall of the uterus or cervix and it grows laterally. That's why the vessels and the ureter, they lie lateral to it. Now let's talk about the diagnosis of the fibroid. The most commonly done investigation is ultrasonography or transvaginal sonography. Secondly, we can do saline infusion sonography or hysteroscopy, that is specifically done for the submucosal type. MRI, whereas it can produce a better picture, but it is not done routinely. If the uterus size is less than 12 weeks, but the patient has pain, we can also go for laparoscopy. We can also arrange for uterine curettage, and we can also do hysterosalpingography, though all of these are rarely done nowadays. Now, a fibroid may undergo variety of changes. So, first change, that is known as hyaline degeneration, that you can see in the center. The degeneration starts in the center and grows towards the periphery, and usually it is painless. Second type of change that you can see is known as calcific degeneration, that happens due to deposition of phosphate and carbonate of lime in the periphery of the fibroid. It starts from the periphery and it grows inwards. Actually, the vessels in the fibroid, they grows from outward to inwards. So in that direction the calcification begins. It produces womb stone appearance in CT. The next type of degeneration which is seen is red degeneration of fibroid, that occurs due to thrombosis of vessels. It is painful in nature. Most commonly it is seen during second trimester of pregnancy. If you do blood investigations, you can find leukocytosis and raised DSR. Radiologically, you will find on sonography hemorrhagic areas which are hyperechoic. Next change that can be seen with the fibroid is a Psychometers change. It is usually seen in females more than 40 years of age and mostly in postmenopausal women. It is the least common type of change in fibroid, accounting for around 0.5% only. In CT scan, you can see air fluid levels in case of Psychometers change. Other changes or complications, in postpartum period, you can see fibroid infections. Then there will be blood-stained vaginal discharge present. And other complications include torsion of the fibroid. That is a very painful condition. So complications of fibroid include postpartum hemorrhage, red degeneration, sepsis, uterine inversion, infertility and abortion, malpresentation, and torsion. There is one condition known as Myometers Erythrocytosis. It accounts for only less than 0.5%. In this condition, either the fibroid or the kidney produces more erythropoietin, and this erythropoietin causes more synthesis of RBCs, causing erythrocytosis. So this is known as Myometers Erythrocytosis. There is another condition that is known as disseminated intraperitoneal leiomyomatosis, is seen either in pregnancy or in patients who are under OCP. Routine management that has been done. Now before going to the management of the fibroid, let's learn about a new drug that has been recently approved by FDA in 2020. The drug is known as Oriahan. It is used for heavy menstrual bleeding with perimenopausal women. So the components of this drug are elagolix, estradiol norethindrone acetate. Now, let's come to the management of the fibroid. The fibroid, if it is asymptomatic, there is no management routinely required. But being asymptomatic, if it is associated with infertility or torsion or chances of torsion, or if the fibroid is associated with urinary tract infections or any malignancy or rapid growth is seen in menopausal women, then treatment of the fibroid becomes necessary. So, what are the drugs that are being used for fibroids? Number one, antiprogesterones like mifepristone or RU486. Second type of drugs are GnRH analogs. So, GnRH agonists like goserelin, leuprorelin, nafarelin, buserelin, these are the drugs which are used. As GnRH antagonists, we can use cetrorelix and ganirelix. Third category of drugs like levonorgestrel releasing intrauterine system, they are also used. Fourth category, selective progesterone receptor modulators like esoprisnil. Another drug which was previously being used is danazol, but now it has been not used so much due to its androgenic side effects. Now, you must know about routes of GnRH analogs. We use hystrelin and goserelin as subcutaneous depots that we can use. There are three drugs that we can use intranasally. One is leuprolide, nafarelin, and buserelin. Leuprolide can also be given intramuscularly. So, what are the surgical management of fibroid? One procedure that is commonly done is myomectomy. It preserves fertility. Myomectomy can be hysteroscopic or it can be vaginal. The next procedure which is done is uterine artery embolization. That is done with PVA or polyvinyl alcohol microspheres that is injected into the uterine artery. One thing that you must remember, it cannot be done on nulliparous women because there is risk of infertility. Next procedure is ND-YAG myolysis. The mechanism is coagulation of fibroids. And MRI guided FUS, that is MRI guided focus ultrasound, that also can be used to coagulate the fibroid, causing coagulation necrosis. Thank you for watching.